This morning, I have the privilege of introducing and welcoming Dr. Anwar Jackson. He is currently the Ryan Residency Program Director at Aurora Healthcare OBGYN Residency in Milwaukee. Prior to joining Aurora, Dr. Jackson completed his undergraduate studies at Howard University, medical studies at UT Southwestern, and OBGYN residency at Hurley Medical Center, Michigan State University. And then followed by complex family planning fellowship at the University of New Mexico. When he's not working, he's enjoying our fine Wisconsin summers, kayaking and hiking. And so please join me in welcoming Dr. Jackson this morning.
All right. How's everyone doing this morning? Wait, can you hear me okay? Okay, perfect. All right. So today's talk is titled "The Wide and Wonderful World of Long-Acting Reversible Contraception." It's going to be a little different than a standard grand rounds. There's not going to be a whole lot of like didactic information. This is really more of a be aware of what's out there and what to do when you come across it. But we'll kind of go into a little bit more details as we go through the presentation. I do have a disclosure that's actually very pertinent to this. I'm technically a certified Nexpedon trainer. I'm for Organon, but that's not going to affect what we're going to talk about today. Well, there is one slide where it's going to kind of come up, but just one slide. All right, so the objectives for today, we're going to start by briefly summarizing the different LARC options that are available in the United States. And then we'll kind of go into more details about what's available outside of the United States. And the reason we're going to focus on this today is because, you know, at least in Milwaukee, we have a lot of patients who come from outside of the United States. There's a big refugee population from all over the world. And lately, we've been seeing a lot more people come with like things that we haven't seen in the United States as far as LARCs go, and they want them removed. And so we're just gonna go over like what's available outside of the United States, what to do when you encounter those things. And then hopefully you'll be able to apply the information you learned from today to your practice. And when you guys are out in the real world seeing patients after residency. All right, so we're gonna go through a very brief history of LARCs. It's a lot of information on this slide. I'm gonna try to run through it real quick. So in 1909, there was a German doctor, Richard Richter, who came up with the idea for using intrauterine devices. And his initial idea was to use silkworm gut as sort of like a way to prevent, kind of create an environment where it was very hard to become pregnant. And then for a while, that was kind of what people used until around the 20s and 30s, when you had three different physicians and scientists kind of independently come up with a different set of IUD systems. And so the first was Carl Proust, who he took like the silkworm gut idea and he thought about adding a string to it to help make it easier to remove the IUD. And then later on, you hear Ernest Grafenberg, who came up with adding silver wire to those silver strings to help identify the IUDs in case they got lost. X-ray kind of came onto the scene medically around like 1890s, early 1900s. And so there was this idea to take advantage of that technology in case you had people who you couldn't really find the strings, you could just do a quick X-ray and identify them now with Grafenberg's design. And then in Japan, there was Dr. Tenrai Ota, who thought about adding golden balls to the silver wire, and that created something called the Pressure ring. And then for a while, things kind of stayed the same until 1962. I don't know, has anyone heard of like the Lippies loop? Yep. So that's where that came from, Jack Lippies. It's basically, I should have included a picture in here, but imagine like a really weird S-shaped curve, kind of looks like a tornado. If anyone has the Twisters movie on the mind right now. And that had a nylon string attached to it to also make it easier to remove. And then in 1969, you have the first copper IUD. So that was a kind of a joint thing between American physician Howard Tatum and a Chilean physician Jaime Zipper. And so they created the T-shaped device that we know today, or at least the early forebearer of what we know today. And they wrapped 200 millimeters squared of copper around it. And the thought process at the time was they'd done a lot of studies to look at the effects of copper on the ability to prevent pregnancy. And so there was a lot of good data in animal models. And so they decided to think of a way to test it out in human models. And that's how we got the first copper IUD. And then the year after that, we have our first hormonal IUD. So there's an Italian physician, Antonio Scomegna, who developed Progestastart, which is basically the first progesterone IUD. And then we're going to get into sort of the dark times. So in 1971, the H. Robbins pharmaceutical company develops the Dalcon Shield. Has anyone, how many of you have heard of the Dalcon Shield? Yeah. Yeah. So the issue with the Dalcon Shield, so at the time, it was a brand new IUD. People thought it was really going to revolutionize contraception. There was a fatal design flaw in the Dalcon Shield in that it had strings like a typical IUD, but the strings were not airtight. And so it was very easy for ascending infections to get into the uterus, and that created a lot of problems. And that's kind of how you get I'd say it's less common today, but you still see a lot of people think about, oh my goodness, I can't get an IUD because I'll get an infection, I'll lose my uterus. So all that comes from the Dalcon Shield. So for a while, people weren't using IUDs. They kind of like fell off because of that. So then in 1983, there was a Finnish company, LARCs, who tries to take things in a different direction. Instead of using intrauterine devices, they thought about other ways to provide long-term protection against pregnancy. And that's where we get the first idea for a plastic implant inserted into the arm. So in 1983, you get the Norplant. And we'll talk about this in a little bit, but basically, so today we know and love the Nexplanon, nice little one rod. Norplant had 6 rods. So like as you're inserting it, it's like 6 different rods that go into your arm. So it was effective, but the design was improved on over time. And then in 1984, we get the copper IUD that we know today, the Paragard. By the 1990s, people looked at the Norplant and thought 6 rods is too many. We should probably like pare that down a little bit. So then it went from 6 rods to 2, and that's what we call the Norplant 2 or Jadil. And that's pretty much that's used today in a lot of different places. It's not really available in the United States right now, but there's still other countries in the world that use the Jadil, and you'll see that sometimes when people come from other countries. In 1998, you have the Implanon, which is basically the Nexplanon without any without any barium to identify it on X-ray. So really the big change from Implanon to Nexplanon is adding barium so you can actually identify it on X-ray in case it gets lost or misplaced. In 2000, you have the Mirena. 2010, you have the Nexplanon. 2013, Skyla. 2015, Liletta. 2016, Kylena. So we're at this point pretty much caught up to the modern day. All right, so we're going to briefly go through the LARCs available in the United States. So as far as subdermal implants, Nexplanon is pretty much the only one we have available today. Implanon isn't really used, they stopped making Implanon just because Nexplanon was a better design as far as like identifying it in case that it gets lost. And then you have 5 different IUDs, which is actually really good because when I would, back in my day, we had Paragard and Mirena. And so pretty much since medical school, we've had like 3 different more IUDs. So Liletta, Kylena, and Skyla. And hopefully we'll have some more, which we'll kind of get into towards the end of this talk. All right, so a brief recap, Nexplanon, 4-centimeter radiopaque plastic rod. It contains the progestin, etonorgestrel. It has 68 milligrams of that. This is my Organon plug. So as an Organon certified trainer, I have to tell you, it is only FDA approved for 3 years. That hats off now. We have good studies showing it's good for up to 5 years. So, and that number will probably go up as we do like trials to see like how long can it actually last. The number actually might go up in the future. Its main mechanism of action, it thickens the cervical mucus and helps prevent ovulation. And I'm sure you guys have like seen this during ACOG reviews or have had attendings tell you, but as far as preventing pregnancy, it's actually like the best thing we have. Better than getting your tubes tied, better than IUD. The failure rate's only 0.05% in the first year. All right, so then next we have our Paragard IUD. Basically, it's the T-shaped device. And the reason I mentioned the parameters here is because like when we talk about the different IUDs available, really the biggest things that change are basically the shape and like how big they are. And that's important for patients who may be uncomfortable with different sizes, and you can try different sizes if you have those options available. But as far as the Paragard goes, it's 32 millimeters wide and 36 millimeters long. It's a T-shaped device. Um, this is an interesting note that a lot of people don't think about, but when you hear like the copper T380, basically the T stands for T-shaped. The 380 stands for the millimeter squared of copper that's wrapped around it. So when you see different IUDs, they'll see like different names based on that. Like we'll get into those in a little bit, but um, that's sort of the defining point of the Paragard. It's FDA approved for 10 years, but we know it can last for up to 12 years. Basically, it makes the uterine environment inhospitable to sperm, and so that makes it difficult to become pregnant. Its failure rate's pretty, I mean, as far as LARCs go, it kind of has the worst failure rate. It's still pretty good. Like, if you told me, if I could get pregnant, if you told me that if you use this, there's like a 0.6% chance you'll get pregnant, I would take those odds, but there are more effective options available. And then the good thing about Paragard is that it doubles as emergency contraception. So quick plug, if you have someone who comes in, recently had unprotected sex, within the past 5 days, you can put a Paragard IUD in to help make sure that they don't get pregnant. Then next we have our Mirena IUD. It's a little smaller than the Paragard in terms of, so it has the same width as Paragard. It's 32 millimeters wide, but it's also only 32 millimeters long, so it's slightly smaller than the Paragard. It's also T-shaped. The big difference, of course, is that instead of having copper, it has hormones in it. Specifically, the levonorgestrel type of progestin, and it has 52 milligrams of that. This one, so, for years, initially when I started, it was only approved for 5 years, and then it went up to 6, then it went up to 7, and now it's good for up to 8 years. As far as the contraception option, the FDA still says it's only approved for 5 years as far as controlling abnormal uterine bleeding, which is the other kind of plus side effect of Mirena. As far as mechanism of action, it thickens the cervical mucus and inhibits sperm motility. And then it has a really good failure rate of 0.2%. So I always tell people, as far as like preventing pregnancy, it's like one of your best options. And then like copper IUD, so this came out a few years ago. People in Utah did a study to look at if Mirena IUD was non-inferior to copper IUD as a form of emergency contraception, and now we have pretty good data showing that it is non-inferior. So the Mirena IUD also doubles as emergency contraception, which is a good plus. It's the exact same picture, because Liletta is essentially the exact same thing as Mirena. Really the biggest difference between, I mean, there's not even a difference. Really the big thing, as I'm sure you're all aware, pharmaceutical companies kind of do their own thing in terms of like patenting and protecting their products. And so Liletta was like a joint effort to kind of get around Bayer's monopoly on Mirena. And so Liletta is basically like a generic version of Mirena. It's the exact same thing, exact same efficacy. But depending on the setting you're practicing in, it can be a lot cheaper for patients. And so that's really like how Liletta came to be. But basically it's the same thing as Mirena. Where you start seeing differences are in the next set of IUDs, so Kalina and Skyla. So doubling back real quick, so Mirena and Liletta, they're 32 millimeters by 32 millimeters. Most people can tolerate them fine, but that does make some people uncomfortable. And so you start having production of smaller IUDs that could be more comfortable for patients. And so Kalina is a smaller progestin IUD. It's 28 millimeters by 30 millimeters. But because of its smaller size, it can, has a smaller dose of progesterone. And so it has levonorgestrel just like Kalina and, just like Liletta and Mirena, but instead of having 52 milligrams, it only has 19.5 milligrams. And because of that smaller dose, right now it's only approved for 5 years for contraception, but that number might go up over time. But the mechanism of action is the exact same. It thickens the cervical mucus, creates a environment that makes it difficult for sperm motility, and it also has the same failure rate of 0.2%. Skyla, kind of the same thing, except it has a smaller dose of progestin. So instead of the 19.5 milligrams of levonorgestrel, it has 13.5, which makes it same efficacy, but for a shorter amount of time. So instead of being effective for 5 years as a mode of contraception, it's only good for 3 years. But other than that, it's the exact same. All right, so now we're getting into the fun part of the talk. So in the rest of the world, there are other subdermal implants. So, like we have Nexplanon available here. Other places have, in addition to Nexplanon, they have Norplant 200L. I put Norplant on here just to kind of show you how you get 6 rods in, but that used to be one that was available. It's not really available anymore just because Norplant 2 was a better design. I shouldn't say better design. It was a more practical design for patients and people putting them in. And then you have the different types of IUDs. So we'll talk about Levosurit and Jadis IUDs. Those are IUDs that are available outside of the United States. They're basic, I mean, we'll talk about them, but basically they're very similar to the hormonal IUDs we have available here. Where you start seeing differences is that in the rest of the world, there are a lot more options for copper IUDs, like a lot more. And that does create problems for some patients. So for example, you might have people who really want to do the Paragard IUD, but because of the Paragard size, they have a hard time tolerating it. And we'll kind of talk about the IUDs that are available elsewhere, like in North America. So sometimes people will employ outside means to get those IUDs, which more power to them. But we'll talk about all that. All right, so starting with the Norplant. All right, there was a picture here. Imagine you have 6 rods. So they're all 4 centimeters long. Basically, if you have your arms splayed out, we'll kind of cheat forward. So instead of, this is Jadil, instead of having 2 implants here, you basically have like 6 rods kind of all splayed out along the upper arm. Back when it was produced, it was had an efficacy of up to 5 years. It had levonorgestrel, so kind of like the Mirena and kind of like the different hormonal IUDs that had the same type of hormone, which is different than the Implanon and Nexplanon. But it had the same purpose. It thickened the cervical mucus, prevented ovulation. Its failure rate was the same as for like the current Nexplanon. So it had a failure rate of 0.05%. But because they came up with the Norplant 2, you don't really see them anymore. So the US stopped making them back in 2002, and then global production stopped in 2008. So I have yet to see anyone come in with a Norplant. I guess it's theoretically possible, so just be aware. If someone tells you like, yeah, I have this implant in that was placed 20 years ago, just be on the lookout that, hey, there might be 6 rods here. Let me do a good physical exam to see if I can feel more than 1 or 2. All right, so then after Norplant stopped being made, they came out with Norplant 2. So it's kind of the same as Norplant. It's the same type of hormone as levonorgestrel, 75 milligrams, but instead of having those 6 rods, it's just 2 rods. And the way it's placed, it's actually kind of weird. I wanted to include a video, but I thought it would be too much trouble. So basically, if you think about how we put Nexplanons in, it's kind of a similar trocar, but instead of just going in once, you basically kind of go at an angle. So you go in with your trocar, you go at an angle, you insert the first rod, and then you pull the trocar out just enough, but not all the way out, and then you re-angle it down here, and you put in the second rod. So just like Nexplanon, it has efficacy for up to 5 years as far as a contraceptive method. And we don't sell them in the United States, but it's a very common LARC outside of the United States. And so if you have a lot of patients, I mean, it's coming in Europe, it's coming in Asia. Where we mostly see it in Milwaukee is people who, we've had a large increase in people coming from different parts of Asia because of different conflicts there. And so a lot of times they'll say, yeah, I have an implant. And then when you're palpating to see where it is, you're like, oh, there's 2 here. So that's kind of where it comes up mostly. Taking it out is, we'll get into how to take it out later, but a quick, basically the quick and dirty of it is, it's the same as Nexplanon. You're just mindful that you're taking out 2 instead of 1. All right. The next one is Levosurit. That's the hormonal IUD. It's literally the exact same thing as Mirena. Really, the big difference is that it's not available here, but it is available in the United Kingdom. So there, it's approved for 6 years. It could potentially be longer, but talking about drug regulations in the United Kingdom is a whole different talk for another day. It's above my pay grade. But it's basically the British version of Mirena. The biggest difference, though, is that the inserter is slightly larger than the inserter for Mirena. So, the Mirena inserter, its diameter is like 4.4 millimeters. The Levocert inserter is 4.8 millimeters. So it can be slightly more comfortable for people when they put it in. But other than that, it's the exact same as Mirena. It just goes by a different name and has a different inserter. The Jadis is another hormonal IUD that is essentially like their version of Skyla, like exact same as Skyla, like the exact same. It just has a different name. And it says FDA approved here. So the reason it says FDA approval for 3 years is because I think it's technically, so for a time they were trying to like bring it to the United States. And so there was an FDA approval process. So it's technically FDA approved, but it's just not available in the United States right now. But it could be potentially in the future. But at the same time, it's literally the same thing as Skyla. So I don't know if you're really going to see it that much in the United States. All right, so we're transitioning to like the really, really interesting part of the talk. So in the hormonal IUD world, everything's kind of the same, more or less. You have different sizes, you have different doses of progestin, but everything's more or less is pretty much the same. Same thing with subdermal implants. The biggest difference is you have 1 versus 2. Copper IUDs are different. Copper IUDs get kind of wild. And there's a lot of different reasons for that, a lot of historical reasons that we'll get into. But basically it breaks down into like the different shapes of IUDs. And so there's like all these IUDs listed here, those are all T-shaped IUDs. Then you have IUDs that are literally like a U shape. You have IUDs that are frameless. And you even have IUDs that are spherical. So when they're deployed, as they're deployed, they start off like a string, but then as they're deployed, the string kind of curves into a little ball. And so we'll get into all that. All right, so this is the Mona Lisa. It's a copper IUD. The biggest difference with the Mona Lisa between that and the Paragard IUD that we know is basically the size of the device itself. This picture kind of cuts it off a little bit, but on the right-hand side, this is like the standard Paragard IUD. So you have like the 32 millimeters in width, 36 millimeters in length. The Mona Lisa IUD is much smaller. So it's only 24 millimeters in width, 30 millimeters in length. But the amount of copper that it has is the exact same. So they both have 38 millimeters squared of copper wrapped around the device. And so a lot of people who have issues with getting the Paragard IUD placed because of the size, they'll try to get the Mona Lisa. Unfortunately, the Mona Lisa is technically not available just yet in the United States, but it is available in Canada. So what some people will do is they'll go to Canada by whatever means, get the Mona Lisa IUD and then come back here. The reason that's important for us is that sometimes patients do that and like you don't know. And so they'll tell you that, hey, I had this like IUD placed and you're thinking like, okay, it's Paragard. But then when you try to, if there's issues with not seeing the strings and you're trying to do imaging, it looks a little different than the Paragard because it's much smaller. So then you have to be mindful of like, hey, where did you have it placed? And then they'll tell you Canada. And they're like, okay, I see what's happening. But really the biggest difference is the size to make it more comfortable. Aside from that, placing it's the exact same, taking it out is the exact same. Ideally, the strings will be visible to the os. You just use a ring forceps to grab the strings and then pull it out. There are some studies in the family planning space that are basically looking at comparing efficacy, because like right now there aren't really like there's not a whole lot of data in the United States as far as the efficacy of the Mona Lisa. So there are some studies going on looking at the efficacy of what they call like the mini copper IUD versus like the standard Paragard IUD. And it's basically a ploy to like get it available in the United States, but that still might be some years away. Hopefully less years than more. All right, so this next one it's technically like an M-shaped IUD. It's really kind of like a curved T, but they call it the multi-load copper IUD. So again, the really biggest difference between this and the Paragard is that instead of having like these T's splayed out, you have these like curved, kind of curved M-shaped wings. And what that does is that if you imagine like the cavity of a uterus, instead of having like this random T that's just sticking out in the sides, it's designed to kind of like accommodate the curve of the uterus a little bit more, while at the same time having these projections that kind of keep it in place. With the multi-load copper IUD, it kind of has the same amount as a Paragard. So instead of having 380, it's 375 millimeters squared. So almost the same, but not quite. And its efficacy is up to 5 years. This one, not available in the United States, but it is available pretty much everywhere else in the world. So we'll see a lot of patients come from Europe, a lot of patients come from Asia who have the multi-load copper IUD. This next one is the Flexi-T. So again, what the biggest difference that you'll see with the copper IUDs is basically the shape and the amount of copper available. So this one's the Flexi-T because it has a T shape like your standard Paragard, but these wings kind of bend down. So they're literally flexible. That's why they call it the Flexi-T. It does have a different amount of copper in it. So instead of having that 380 millimeters squared, it only has 300 millimeters squared. Then they do make two different types of Flexi-T. So there's like the smaller version, there's a bigger version. The smaller version is 23 millimeters by 29 millimeters. So 23 millimeters in width, 29 millimeters in length. The bigger version is 28 millimeters in width, 32 millimeters in length. And the bigger version sometimes has the same amount of copper that you see in a Paragard IUD. So sometimes it does have the standard 380 millimeters squared, but sometimes it also comes with just 300 millimeters squared. And this one is also efficacious for up to 5 years. Then next, we kind of get into the frameless IUDs. So this is the Gyne Fix. This one's also available mostly Europe, Asia, Africa. Sometimes you see it in Canada. But instead of having so if you think about the IUDs we've covered so far, there's a plastic frame that has copper wrapped around it. This is frameless because it's literally just a string that has like copper rods around it. So from a comfort standpoint, instead of having to have a frame inside the uterus, it's more comfortable, ideally. The reason you see this like little knot at the top is it's designed to anchor the frameless IUD to the uterus. So sometimes taking it out can be a little bit difficult because of that, but ideally, just like with any standard IUD, you have strings that kind of stick out of the cervical os, and you can just grab the IUD and pull. With the frameless IUD, it usually has 330 millimeters squared of copper around it. And so you kind of see these like copper rods. Basically, that's where all the copper is. So you have these rods that are stacked on top of each other along this nylon string. And then that's kind of what provides the copper necessary to help prevent pregnancy. All right, so this is like the weirdest one. So this is called the intrauterine ball. This picture doesn't really do it justice, but basically what it is it's kind of like the frameless IUD in the sense that there's not really like a plastic frame device, but you have these different copper spheres that are attached to a string. But what happens as you're deploying it is that the string kind of curves and it makes this ball inside the uterus. This one kind of has the same amount of copper that you see in a lot of the different copper IUDs around the world. So 300 millimeters squared of copper is kind of like a pretty common amount of copper that you see. The diameters of the balls are only like 12 millimeters, so they're very small. And it's also good for up to 5 years. All right, so we're kind of getting into the historical portion. So people develop IUDs for lots of different reasons, mostly to provide different options for contraception. But every now and then you see them intertwined with policy as well. So historically in the United States, the issue was that there were a lot of like forced sterilization, forced contraception policies that also aided the development of IUDs for worse. We don't have to deal with that anymore. There's a lot more awareness around reproductive coercion. You kind of had a similar thing happen elsewhere though. So in China, back during the 60s and 70s, when there was the one-child policy, there was a big push to develop contraceptive devices that basically kept people from getting pregnant after having their first child. And so this is when you start seeing the development of stainless steel rings. Um, you don't, so these aren't made anymore, they're not really placed anymore. But the goal of the stainless steel ring was to basically use steel as a conduit for it. Not, they didn't really have copper, but the steel was designed to kind of act similar to copper in the fact that it created an environment that was hostile to sperm. Um, the stainless steel rings are basically like just literally exactly this. It's just one giant ring made of steel. Um, they intentionally lacked strings, and so we'll talk about that in a little bit. But the point was that once it's in, it stays in, doesn't come out because we don't want you to have any more kids. They actually stopped making them in 1993 because the failure rate was so high. The failure rate was like 10%. So, you know, like most IUDs, the failure rate somewhere between 0.2 and 0.8%, but the failure rate for this one was like 10%. So that's why they stopped making them. But because they were designed to be there forever, you still have people walking around that have these in place today. And so what sometimes you'll see is people come in who say like, I had my IUD placed 40 years ago, I'm ready for it to come out. And then you kind of do a little bit of homework to figure out what kind of IUD is it. And if it's this one, then good luck to you. But we'll talk, we'll talk about tricks about how to get these kinds of IUDs out. And then the variant of the stainless steel ring was like this uterine shaped IUD. So it's literally kind of the shape of the uterus, the uterine cavity. But other than that, it's kind of the exact same. Its failure rate was really high, so they stopped making them. But there are still people who have them just because they were designed to stay in forever. Because you had such a high failure rate with the stainless steel IUDs, and because there were some concerns about the effects of the one-child policy, which is no longer a thing, there was a lot of development in China around new different types of IUDs. And so much like the rest of the world, they turned towards using copper IUDs. And now there's like several copper IUDs that are available in China. This one is like, they call it I can never pronounce this right. It's like AIMU copper IUD. So it's also like a U-shaped device. This picture kind of cuts off at the edges, but if you can imagine like the shape of the uterine cavity, it sort of has that same contour. But you know, instead of having stainless steel, it has the same type of copper that you see in the copper IUDs we have here and elsewhere. And it's good for up to 10 years, kind of like our Paragard IUD. This doesn't have a string in this picture, but these do come with strings. And then this is another type of copper IUD. They call it the gamma copper 380. Again, most IUD names are based on like the shape of the IUD. So if you look really hard, it looks like the Greek letter gamma. But it also has like 380 millimeters squared of copper, just like the Paragard. All right, so now that we've gone through what's out there, what do you do when you encounter the unknown? All right, so there are some practice considerations. So we kind of touched on this briefly, but particularly in Milwaukee and other large cities, there's an increased population of people coming from other parts of the world, and that's talking about social political conflict leading to mass migration is a whole nother topic also above my pay grade. But you do see a lot of people coming from different parts of the world that have different types of LARCs that we aren't experienced to here. And so really the big things are figuring out what people have, and then if they want them out, then what are the things you need to do to remove them. So just like any, you guys probably haven't started studying for boards yet, but like the one thing they always tell you is start with the history and physical, and that's true for like everything. So your first tool is like history and physical. So you want to ask people like, how long ago was it put in? What kind of symptoms have you had from it? Have you been having any symptoms at all? And then as you're doing your physical exam, particularly if it's like an implant, you like want to check to make sure, am I only filling one rod or two? If it's an IUD, sometimes you can see the strings through the cervical os, but if not, you might need some additional tools. And so that's where using your ultrasound comes in, to get a good view of like what type of IUD people have. And then based on that, you might need to do hysteroscopy as well. So as far as removing the jadil, um, there's like a whole like multi-step process to this, but it's not really that complicated. I'm kind of like reaching through it real quick. This first report just says like have everything you would have ready for an Nexplanon removal, so sterile gloves, lidocaine, betadine or chlorhexidine, something to clean the area, gauze to like wrap everything up afterwards. Really the biggest thing is you want to like palpate to see like, do you feel one rod or two? And if you feel two rods, usually it's going to be in this V shape. So what you'll feel is like as you're running your fingers along the outer arm, you're going to feel like kind of something here on the outside, another something here on the outside. And then as you're running your fingers, it kind of comes closer together to make a V. Then that's your big clue that they have a jadil in. Again, I've never seen anyone with an original Nor plant, mostly because they don't make them anymore. But it's still possible that they're out there. So for filling a Nor plant, you kind of do the same thing, except instead of filling 2 rods, you're going to fill 6. And then you're going to have a fun time removing each one. So once you confirm that they have 2 rods and not 1, your goal is to, as you're injecting lidocaine to help numb the area, you still kind of inject it at the incision point. So if you think about, I guess traditionally how a lot of family planning people take out Nexplanons is they don't really go overboard with lidocaine. Really, you just need like a really small amount of lidocaine where you're going to make your incision. And so just like with Nexplanon, the goal is to inject the lidocaine underneath the rod so you don't cover it up with the lidocaine. Because what happens when you inject it above is that you kind of push the rod down and it's harder to take out. If you inject the lidocaine underneath, you're pushing the rod up, makes it easier to take out while also not taking away any of the benefits you get from lidocaine for pain control. Really the biggest thing is that you don't need to inject like twice because you're still only making 1 incision to take out both rods. So you make your little incision after the patient has adequate pain control. Again, doesn't have to be a big incision. Even though they have 2 rods, the rods are small, they're coming out the same incision. So you don't need to make like this large incision. You really just need to make the same type of incision that you would when you take out an Nexplanon. And then after you make your incision, it's sort of like the same thing with Nexplanon. You try to like break up the tissue, sometimes you have a scar tissue that forms to create the sheath, the tissue sheath around the Nexplanon. So you break that up, just like you would with Nexplanon. You identify the first jadil rod implant, you break up that sheath to take it out. And then you do the same with the other one, because remember, if it's placed correctly, the other one should be right. Even though there's 2 rods, they both should kind of be joining in the same area. So once you find the first one, the other one should be pretty easy to find if it's placed correctly. Then from that point, it's breaking up the sheath and then taking them out. Quick caveat, they use forceps here. I guess that's like, actually even Nexplanon, that's how they teach you to do it. There are people who don't use forceps like me. You can just use the scalpel to kind of take it out. But that's a different topic for another day. So once you like take everything out, then you place bandage, wrap it up just like you would with the Nexplanon. Sometimes you can place theory strips. Sometimes you just need a Band-Aid and then wrap it with gauze to help reduce bruising. So taking out jadil, it's fairly straightforward. Really the big thing is just recognizing that they have a jadil and not an Nexplanon. So what about the IUDs? Because even though there's only really 2 implants available in the world as far as like contraceptives go, there's like many IUDs available. And some of them don't have rings, some of them have a little like knot to like keep it in place. That can change how you take it out. So what do you do? So after you're doing your history and physical, trying to figure out what kind of IUD people have, really the next big thing is as you're doing your physical exam, you're trying to assess like, are the strings visible? If you do see strings visible to the os, then at that point, you can kind of treat it like a regular IUD. Because at that point, it should be able to come out if you grab the rings with the forceps. um, if you don't see the strings though, then you kind of do what we would do with IUDs we have here. So the next step would be to do an ultrasound to determine location. And the benefit of ultrasound in this particular instance is that you're able to see like what kind of IUD is it. So even though there's a bunch of different types of IUDs with different shapes, you can usually get a good sense of like what kind of IUD it is with an ultrasound. The main caveat being though, like a 3D ultrasound might work better. Just because with a regular 2D ultrasound, you'll see like, yeah, there's something here. And it's like, okay, great. I know there's something there. That's why they're here. But a 3D ultrasound will kind of help you give a better idea of like what the contour of the IUD is and provide you more information about exactly what type of IUD they have and then kind of the next steps you need to take it out. Once you have the type of IUD figured out or a good guesstimate of what type of IUD they have, then from that point, it's kind of using the tools we would use for like a difficult IUD removal. So you might see like the IUD hook. If they have strings, you can use the IUD hook to kind of like we would do it with any lost strings with the IUDs we have here. You insert it into the cervical os to try to like grasp the strings if you can and then pull the strings out. If that doesn't work, then you have packing forceps, you have alligator forceps available to grab the IUDs. But remember, ideally, if you're going to do that, you should have like, you should be doing it at ultrasound guidance, just so you don't run the risk of like perforating the uterus. As far as like pain control goes, it's sort of the same thing with difficult IUD removals for the IUDs we have here. So you can consider doing a pericervical block. That's actually like the best evidence we have so far with regards to pain control for difficult IUD removals. But you can also do like conscious sedation if you have it available. Usually like in our clinic, we don't really have access to IV sedation. So we'll give people like oxycodone and Ativan to kind of help take the edge off a little bit. And then, of course, your last resort is doing hysteroscopy. So that's sort of like the gold standard for anything in the uterus when you're taking out an IUD. That's difficult to come out because with the hysteroscopy, you're able to directly see exactly what you're dealing with and then kind of come up with a game plan. For IUDs that don't have strings, so that's mostly like the stainless steel IUDs that, again, haven't been made in a long time, but people still have them out there. You'll see a lot of different things about tricks people do. So one trick that's really kind of interesting is that you make it have strings. And so you can, like under hysteroscopic guidance, you can kind of like guide a piece of like nylon like around and through this ring, and then use that to like pull the IUD out. All right. So that's pretty much all I have. So really the big takeaway from this is that we have like a lot of things available here in the United States, but there's a whole lot more out there. And so when you're encountering patients from different parts of the world, just be mindful that they might have a different LARC that you're not used to, and just be prepared for that when it's time for it to come out.
Thanks so much for this really interesting talk. I was just curious with the copper IUDs that you went through. You said a couple of them had the exact same amount of copper as the Paragard. Why is the efficacy only 5 years for those if it's the same amount of copper?
Yeah.
And also, is Paragard going to ever make a better inserter?
But both of those are great questions. So this is above my pay grade, but like as far as like approving efficacy of like how long things last, like there are different regulations in different parts of the world. And so like ideally they should be able to last the same amount as Paragard, but for whatever reason, the regulatory agencies like in those countries have said it's only good for 5 years. But in theory, it should be efficacious as long as Paragard is. As far as like making a better IUD, that is so there's an external push to make a better IUD. I think historically speaking, the makers of Paragard haven't really been motivated to make a better IUD, because when you have cornered the market, you don't really need to make one, because what choice do you have? But there is an external push from the family planning world for them to make a better IUD. Mostly because Mona Lisa is available like north of the border. And so now I think they do feel the pressure, like, oh crap, people are like leaving the country. That's our money. So
Thank you, Dr. Jackson. I just want to say thanks for coming over, and the world perspective, I think, is so important. And raise your hand if you actually have had to dig out Norplant IUDs. Oh my gosh. Wait, we got somebody. Okay, we got somebody. I spent a better part of my residency taking out the 6 rods. And this has been an improvement definitely over the century. And I guess I didn't realize the history of the IUD going all the way back well over a century. And so I thought this was just fascinating. And I really appreciate you coming down and talking to everybody. I want to say that we're going to take a good 10-minute break. What time is it? Let's just see. It's 07. Okay. Why don't we come back at 8:17? And those nurse practitioners, CNMs, and PAs that are on the line right now, go ahead and stay on the line. And right after the break, Molly Lepic is going to take about 5 minutes, the beginning of Grand Rounds, to talk to us a little bit about HealthLink 2.0. So thanks again, Dr. Jackson. We really appreciate you making the trip.